you'll notice that the talk is actually listed to be given by Gilberto Leung, who was unable to come, and so he sent me his 2 talks, which I will give in sequence once we're going. But the first talk is on subdural hematoma, and we'll talk briefly about the pathology and the presentation and management. But, blends into 48 to 14 days, 2 weeks after the injury, and then chronic, which is something of a different pathology, and we'll talk about that later. I won't cover the pediatric subdurals, which hopefully will be covered in the session on the presentation on pediatric head injury. But as you know, the basis for subdural hematomas is a rotational injury, and that there is a relative movement between the brain and the interior of the skull, and that accompanying this rotational injury there is deformation of the underlying brain. So, as we are well aware, acute subdural hematomas are commonly associated with diffuse brain injury of different degrees, and so as listed here, the deep structures may be injured, post-concussive on the basis of diffuse axonal injury. boxes are still punching and producing a rotational strain. And so the mechanism of acute subdural hematoma is very largely the rotational acceleration, to which there will be degrees of direct antero-posterior acceleration and diffuse axonal injury. And the components of the force which will determine which will be the dominant pathology depends therefore on the degree of rotational acceleration and the duration. So that if you look at this slide, you can see that the longer the duration compared with the rotation, the greater will be the proportion of diffuse injury, diffuse axonal injury, and vice versa. Rotational acceleration, if that is the dominant force, then the degree of diffuse axonal injury may be relatively less. And so the acute subdural hematoma is therefore a mixture of an extracranial, or rather an extracerebral clot with pressure and some degree of primary brain injury. So with the acute subdural hematoma, which is predominantly one of rotational acceleration, there may be a relatively less primary brain injury. There may even be, in some cases, a lucid interval, so that the clot may, in its presentation, may be more clinically similar to an extradural. On the other hand, there, as we often will find, there is a degree of brain contusion, and here is shown a burst lobe, a mixture of intracerebral, subdural, subarachnoid blood, which is a harbinger of problems, a potential cause of swelling, so in this instance there is very unlikely to be any lucid interval, and it's an injury which carries a high mortality. So the guidelines, the Brain Trauma Foundation guidelines for the surgical management of acute subdural hematomas, I'll just, the highlights underlined there indicate that a thickness greater than 10 millimetres or a midline shift greater than 5 millimetres on CT should be surgically evacuated. All patients with acute subdural hematomas in coma, that's to say GCS less than 6, should undergo intracranial pressure monitoring. I think I can probably skip that, is that right? Oh, you're not getting that message. A comatose patient of less than 9 with a subdural less than 10 millimetres thick and a midline shift less than 5 should undergo surgical evacuation if the GCS decreases after hospital admission. Also, surgery is recommended if there are asymmetrical fixed and dilated pupils and if ICP exceeds 20. And the timing is that it should be done as soon as possible. The techniques with which you are very familiar, and I'll just point out the importance of the large dural opening because of the potential for brain swelling and herniation. One technique which is shown here, which I used a number of times, is when the brain is very tight and subdural is perhaps not so thick, is to use dural stabs, incisions in the dura. One problem with that is I found when I had to reoperate because of increasing brain swelling and raised intracranial pressure to convert into a larger decompression, that the brain tended to herniate through these stabs, and with the fear and the probability that it actually ended up increasing the degree of brain damage. As is pointed out here, the importance in removing the clot, firstly to identify where the bleeding is coming from, but avoid disturbing clot near major sinuses, and anticipate brain contusion following evacuation, and following evacuation, the possibility of post-operative brain swelling. Hence, the craniotomy should be large and consider a duroplasty and make probability of brain swelling to follow. We've talked about the different ways of ICP monitoring. I wouldn't actually call that prophylactic used in that way. Indeed, our and this further paper from Washington, DC, rather Washington, Seattle, or Seattle, Washington State, I should say, who were a better group of patients. They presented with GCS greater than 12 and nearly 60% of them. And they had an inpatient mortality of only 16%. So really what they are saying effectively is that if the GCS at the time on admission or at the time of the surgery is higher, then the outcome is better. Not at all a surprising result. But what we will address in the next talk as well is that age is important, and the elderly, which is generally described as people over, I think in this group was over 65, then the medium Glasgow Coma score was 8. Some ended up, as you might expect, severely disabled, but a favourable outcome occurred in 40% nonetheless. And so the conclusion from this study was, which was a retrospective study of not a very big population, 37 patients, was that craniotomy for patients older than 65 remains controversial, but this case series supports the notion that surgical treatment is associated with significant post-operative morbidity and adverse mortality. However, selected patients benefit, and a good outcome occurred, as I said, in 41%. So there are difficult decisions in face of clinicians with acute subdural hematoma, and here Dr. Leung has presented us with a few difficult decisions which we might consider as a group. If we looked at the top left-hand corner, a 80-year-old male who comes in with a GCS of 13, He has a post-coronary stent and is therefore on anticoagulants, antiplatelet agents. So how would this group of very experienced neurosurgeons deal with this problem? Anybody like to offer a plan? GCS 13, a finished subdural, doesn't look to be a midline shift to me. Would you observe? Would you operate? Who would operate? Who would drain the subdural? Who would observe? Who would do something about the coagulants? Right, it looks like this looks like a good one for no action. That seems to be the concerted opinion. So if we go to the, perhaps to the one to the left then, a male, 35-year-old male, GCS now 4, with a right fixed pupil, and the left one is reacting but sluggishly. So he's got a, as we can see, a thick subdural with considerable midline shift. It's the subdural is of mixed radiological density. So what would be the, could anybody like to put up their hand and suggest a course of action? Any of the younger neurosurgeons down there whom I don't know, but would anybody care to put their head above the ramparts and offer a plan of campaign? Would you operate? Who would operate acutely? The one on the to your top right? Yeah, 35, GCS 4, one pupil is still reacting. You'd operate? Yep, okay. Would be general agreement with that? Acute, and what sort of decompression would you, how would you operate? Would you just do a flap and take the clot out, or would you do a big decompression? Would you leave it? Hmm? Big flap. Leave it out or not?
Duroplasty.
Yeah, duroplasty. So you would anticipate, in this case, there would be brain swelling. You'd anticipate that problem and do a large decompression duroplasty. And so if we go down to your bottom left hand, which is an elderly patient, 79, but GCS is 15, is asymptomatic. He's got this quite largish subdural. It doesn't tell you there what midline shift he might have. You anticipate he might or might not have some. His brain is a bit atrophied. So would anybody want acute operation on that, or would you wait and see? Observation, yep. And you'd keep him in hospital? Would you repeat the CT scan after a period, or would you just go by clinical monitoring?
Observation in hospital. Observation in hospital.
Yeah, okay, all right. And what about, just to wrap this up, the one with the interhemispheric subdural? Would anybody like to offer a way of dealing with this? I always found this a difficult problem. It's a 68-year-old female, doesn't give us a GCS, but the sign is presumably the GCS is reasonable because we're able to identify from this left leg weakness. Observe or attempt to evacuate if the GCS is straight. that as something to consider. What in South Korea would be the treatment? Yes. Yep. Okay. Okay. All right. Good. All right. Okay. Well, thank you for that. The isodense subdural. Careful not to confuse that or miss it, because it can be isodense. And then we move on to the chronic subdural, which is, as you know, more often occurs in the elderly. There is a trauma history that can be found. Sometimes it may be forgotten. And often in these days, elderly patients are on some form of anticoagulation or antiplatelet agents, more common in alcoholics, and 25% bilateral. And there may be raised cranial pressure, focal events, or seizures. And then the question whether pathology nowadays is generally regarded as being an inflammatory process with hypervascularity of the upper membrane and with recurrent low-level bleeding. And putting in drains into the subdural space, and so they randomly assigned drain into the subdural, and they found that there was a reduced recurrence and a reduced mortality at 6 months. The findings were that recurrence occurred in 9% of patients. Another review now of a number of papers looking at the question of twist drill versus burr hole craniostomy, coming to the conclusion that burr hole is better than twist drill, and that that a formal craniotomy is something that you reserve for recurrence. Anticonvulsants. This abstract review found that and then the medical treatment of chronic subdurals. There have been a number of papers in fairly recent times about the use of tranexamic acid, antifibrinolytic agents, which might prevent the fibrinolysis, which is thought to be one of the factors which leads to repeated bleeding into the subdural space. And in this study, there seemed to be some evidence that it could reduce that, but it was not, as I say, overwhelming evidence. And again, I'd be interested if anybody has experience with that. Steroids, as an anti-inflammatory agent, have been used, and there are a number of observational studies which suggest that small chronic subdurals may resolve better with steroids. And this particular review referred to 5 observational studies who came to that general impression, but of course they pointed out the fact that there were no well-designed trials. So other medical managements for chronic subdurals include ACE inhibitors, which I have no experience, mannitol or atorvastatin. Again, these are not used in my department, and there are no randomised controlled trials, but if anybody has any comments afterwards, I'm sure we would be interested to know them. Now, a few of the problems with subdurals, chronic subdurals. The chronic subdural that occurs sometimes in an over-shunted patient. What do you do with the shunt? Do you leave it alone? Dealt with the chronic subdural. The pressure up and as time. And then the other type of subdural which turns up sometimes in a young patient who does not have any particular bleeding tendency or a history of trauma, that develops an orthostatic headache, headache which seems to be typical of low of intracranial hypotension. DECRA, as you know, which we'll talk about in a moment, had a worse outcome at 6 months, and this was not in the elderly, this was in the under 60 age group. And but other studies which have looked at decompression of craniectomy in the elderly came to the conclusion, or this conclusion anyway, was that it was not worth the while, that there was a 77% mortality at 1 year, and a good outcome did not occur in any whose post-resuscitation score was less than 5. However, the good outcome occurred in 50% if the Glasgow Coma score was greater than 9. So it would seem to me that the conclusion from this paper was, once again, is to be selective and to be active when in that group where you suspect that a good outcome is possible. Of course, the cost of medical costs is something we considered earlier on today, but this slide Gilberto has put in just to make us aware of the problems that the ageing population is about to present us with, that we're about to be overwhelmed, according to this cartoonist, by a grey tsunami, and that's going to have significant effects on the chap holding up the umbrella which says healthcare budget. I'll leave the remaining slides which concern post-injury care of patients with older adults, because I think that these things, including the post-surgical, post-discharge social care, may be covered in the matter of rehabilitation. Perhaps I can just conclude then with the message that geriatrics is not quite the same thing as old age, that you need to look at individuals and assess their prognosis as best you can, because good outcomes are possible. On the other hand, you don't go in and attack everybody. I presume that's what the surgical gorilla would do, but you identify and treat aggressively those with survival injury for a defined period of time. And the quality of life, of course, is the matter which is at least as important as survival. Thank you.
My questions are invited from the audience. No question. So next, thank you, Dr. Farrelly. Next speaker is not there. Not.
So I'm afraid that you're going to have to listen to me for another 20 minutes. And Dr. Sahu informed me this morning that Dr. Kuma was not able to come today to talk about decompression. So I'll just say a few words about it. I had some involvement with the DECRA study and have therefore been quite interested to hear the results of the Rescue RCP study. So I will just briefly, the history of decompression. You may know that Cushing can be accounted as being the first person to use decompression to control intracranial, to try and control raised intracranial pressure. But he was applying it to tumours, sometimes large pituitary tumours and other intracranial tumours, and his decompressions were bitemporal decompressions. In the 70s, Joe Ransohoff in New York began to use decompression in trauma at the last, more or less just before the last gasp. So it was very much a rescue operation, and like many rescue operations, it didn't have very good results. And so he wrote up a number of papers. Joan Venice, a paediatric neurosurgeon, from Yale also wrote papers on decompression in the 70s, and they ended up by thinking that it wasn't really very good. And one of the big problems that they faced was the herniation of the swollen brain, and I think for two reasons. Firstly, they were operating really at death's door, and secondly, their decompressions were not big by the standards that we would regard now. And then the Cochrane review some years ago came up with a sort of an equipoise position that there was not enough evidence to support or deny decompression. And about that time, there were a number of small studies which suggested that decompression was saving lives, it was reducing intracranial pressure, and more people were surviving from severe brain injuries, often injuries with contusions and post-contusional swelling. And so this sort of decompression was being undertaken, often for this sort of the type of injuries shown here, where there are contusions, the swelling gets worse by day 3, and so a very large decompression is done here. There are really two general types of surgical decompression. The bifrontal decompression shown on the top 3 slides, and that top one is typical of the DECRA type of patient with diffuse swelling with no clots and a bifrontal decompression. The lower 2 slides show the type of decompression which is commonly used, or often used in the United States and no doubt elsewhere. In other words, a unilateral decompression. The rationale for the DECRA study, or rather, yes, the rationale for the DECRA study was that there was much evidence linking ICP with mortality, and that the point where ICP really started to tip the balance badly was at about 20 millimetres of mercury. And the Brain Trauma Foundation guidelines, the initial guidelines, recommended initiating treatment when ICP was greater or equal to 20 millimetres of mercury. And there were some papers which suggested that by doing this you avoided late rises in ICP, and that if you delayed, then the late rises in ICP would be worse. Decompressive craniectomy appeared to be, in a number of, say, uncontrolled studies, to be able to reduce ICP. So it was in the stepwise guidelines for the management of traumatic brain injury, and it stood as a third tier in the stepwise process of managing ICP. So the DECRA study aimed to look at early refractory increased ICP. So it defined early in terms of the ICP. The ICP had not gone beyond 20 for more than 15 minutes within a total of 15 minutes within a 60-minute period. And the first line treatment, what we consider first line, namely standard management, sedation, normal PCO2, maybe using mannitol or hypertonic saline, a neuromuscular blockade, having an external ventricular drain, had failed, and the ICP had now been over 20 for more than 15 minutes within the first hour. And so they were then assigned, and it had to be within 72 hours of the injury, and so they were then assigned to either decompression or continuing medical management. And the type of decompression was like this, a large bifrontal decompression with a durostomy. This varied a little bit, either the type that was favoured in Adelaide, which is the fish mouth durostomy, or the other one which preserved the sagittal sinus right down and did flaps on either side. So the inclusions were the diffuse non-penetrating brain injury, and they're under 60, and it was within 72 hours of injury, optimised standard management therapies, and exclusions were mass lesions of any sort of hematoma, and in other penetrating and no chance of survival. This was reported 2011 as the first randomised trial in adults, and it showed a worse outcome at 6 months. It had controlled intracranial pressure. As you can see here, the decompression dropped the intracranial pressure below the 20 mark that it began at, and ran mostly between 12 and 15. But despite this early control of intracranial pressure, which was the rationale for the study, the outcome at 6 months was worse. There were complications, and these are complications of the operation. That is to say, there were a few infections. They were all relatively minor, sorry, I didn't concentrate. So these were the complications. They were relatively few in number, we can say that there were some positive secondary outcomes. By using decompressive craniectomy, the ICP reduced. Consequently, the therapies for increased ICP were less, and the times of mechanical ventilation, the time in ICU, all these things were improved, so they seem to be quite positive. There were some differences in the two arms of the study which had been criticised. There was a difference in pupils at the time of operation, not at the time of registration. Was the sample size too small? There were 175 patients which had been accumulated in multiple centres, and it had taken several years to get that number. But perhaps importantly, was the ICP threshold too low to show a difference? At whatever difference it might, the treating at this low ICP level might have been overtaken by the small numbers, but perhaps in this setting, significant numbers of complications. So was the complication of surgery swamp whatever benefit there might have been from the decompression? And the other, and there was hydrocephalus in 10% of the patients. That's one I should mention. That was numerically the major complication. So it seemed to be that there had been, in effect, a shift from those that might have otherwise died to those that survived with deficit. Another possibility raised by some experimental studies was whether the complication that was significant in this early diffuse brain swelling pathology was axonal stretch. A research paper in 2013 had shown that there was significant strain in the axonal fibres in an experimental model of decompression. You can see in the CT scan that how the frontal lobes have herniated, and that there will undoubtedly be some degree of stretch on those fibres, which can be shown on diffusion weighted imaging. I think I've already mentioned that. So now the rescue ICP. The rescue ICP, which was published only a few months ago from Cambridge, has been awaited for some time because its characteristics are slightly different from those, in fact significantly different from those of the DECRA study. And I would say that they are more in line with the general application of decompression. And that is that it was used as a third-tier intervention, and where everything had failed apart from barbiturates, that it included patients with hematomas which were evacuated or non-evacuated, and it came into function, or it was applied for ICPs greater than 25 millimetres of mercury, and that had been up at that high for up to 12 hours, and that the operation was done in or beyond the 72 hours, which was the limit of the DECRA study. And they also included unilateral craniectomy as well as bilateral bifrontal decompression. So it was I would say more clinically relevant in the sense of clinically relevant to the usual clinical practice, whereas the DECRA study was specifically a study of early treatment of raised intracranial pressure. The DECRA study certainly reduced ICP, and it's confirmed yet again that decompression is a very effective way of doing that. It reduced the immediate mortality, but in terms of the Glasgow outcome scale at 6 months, those with severe disability were increased in the DECRA study in those decompressed patients. There was something like a 35 or 32 or 35% crossover to decompression from the medical arm, and so that that has been noted, and the authors do not think that affects their overall figures. But then, so that's, I think, where decompression stands in terms of the studies that have been done to the present time. It raises the questions of whether or not decompression should be used, given that these results have a worse outcome. It doesn't exclude, however, that within those groups who are decompressed, there are some who made a good outcome who would not otherwise have done so. And so it raises the question of just how we prognosticate once again. What are the elements that we use to try and make a prognosis? Stephen Honeybull in Perth has written a number of papers which I've listed here, which from one of his presentations, considering the ethical considerations of performing it for severe decompression as a life-saving intervention for severe traumatic brain injury, and raising again the problems of prognosticating and how you would then make a proper study which compares like with like, whether the prognosis is in individual patients can be actually said to have improved. So I think that's where we stand, and I've finished with one of Stephen Honeybull's other slides, which is a response to the key questions, which are: is decompressive craniectomy a life-saving procedure? And I think there is so much evidence to say that it is. And we know that many patients whose ICP is going up, particularly those with contusions and brain swelling, that a decompression can save that life. And does decompressive craniectomy improve the neurological outcome? And it would seem that for many patients it probably doesn't. And clearly there are risks associated with the decompressive craniectomy. We've listed those. There are complications that occur after decompression. And so finally, we ended up with what are the indications for surgical decompression. And the question then comes as to whether we can focus, can we look at brain injury in a more broad way than simply the ICP. And Randall Chestnut, who conducted the study, published a couple of years ago, where I mentioned that earlier today in discussion, showed that in the study that he did, that the outcome in a group of patients was equally good whether or not ICP monitoring was used. Nonetheless, he and others recommend that ICP monitoring should be used, but he and others have questioned the focus on purely ICP, and I think this is probably a failure of the DECRA study that it was aimed simply at that modality, at ICP, and as Chestnut says, it joins a list of many other studies which have focused on ICP alone and which have failed to show any benefit. So the question rises whether there are other brain indices which can be used. And I noted this paper published recently from Gupta and Dr. Mahopatra's group on dialysis, looking and finding that in dialysis you can identify the elements in the dialysate which will give you a strong indication of a bad outcome. And so these may be factors, maybe one of the factors, multimodality monitoring, which will be able to sharpen our prognostic abilities and enable us to be able to judge the place of treatments like decompression more accurately. Thank you.
Thank you, Professor. Really can sit down. Standing very long time. Any questions are there or clarifications? I want to make one comment on what Professor Das.
So you be seated. You can hold the microphone from there and talk.
In raised intracranial pressure after trauma, when there is no such space occupying lesion like a large hematoma, only thing available was probably decompressive craniectomy. Now you have put a bombshell on it saying that most of them do not benefit out of it. 6 months after, the results are poor. So can you say, you have, what you have said is microdialysis, and those are not commonly available for the treatment in most of the places. What would be your message to all of us?
Yeah, well, it is a difficult question. It's a difficult, as it raised the ethical question of whether it should be used. I think that we cannot say that within those group of good outcomes who had decompression, whether there are some in that would not have had a good outcome without decompression. So we're still in that dilemma. There may well be, and I would suspect that there are people who survived, whose ICP was controlled early, and who made a good outcome, and who would not have done so without the decompression. And I think that many physicians still think so, including those that were in the trial, because you look at the 32% or whatever it was of crossovers of those that were failing medical management that went to decompression in the rescue ICP trial. So I think at the moment, if you're faced with a situation of uncontrolled ICP and you've gone to the extent of you've made the decision you're going to go barbiturates or not, and most people these days don't, although there was a good presentation earlier about how you could, then I still think the decompression is an appropriate, a valid, justifiable option. I think what it perhaps gives us a bit more information about the advice that we can give, the prognostic advice we can give, that decompression isn't a panacea, it's not a guarantee. In fact, that in some cases where medical management is failing, then I think it is reasonable to do it. And I think it's very hard for example, in a young patient with a diffuse brain swelling where medical management is failing, not to try everything.
Thank you, Professor Riley. Please sit down. I just was starting to speak something about the presentation of Professor Riley and our Japanese colleague. The important thing is that what happens at the time of trauma, we have no control at all. So this is basically towards the management of the secondary problems that creep up after a couple of hours or days, like raised intracranial pressure. Basically, it is not the hematoma, it's the edema or the vascular disturbances. As he has pointed out, that the oxygenation is affected and the neurons die. So basically, our focus is the neurons. The large number of neurons that either die at the time of injury or they go on dying, that is called apoptosis, has to be prevented to get the best result. This part was pointed out by editorial Professor P. N. Turner given in Neurology India towards zero mortality in head injury. This is a very interesting paper, and we can only achieve, you can tackle the chemical process that is going on, because initially it is electrical phenomena, that is what is called concussion, then comes up the vascular phenomena, and then comes the chemical phenomena because of release of various chemical factors. They are the vasoactive, the glutamate, the aspartate, and so on and so forth. So until those factors are controlled, the neurons will go on dying, and we won't have a quality of life. The patient can survive because raised intracranial pressure can be controlled, as has been pointed out by decompression craniotomy. But we will have to, for future research, we will have to look for the process of apoptosis or the progressive neuronal cell death, which is the main factor why the quality of life is not returning back. So I think with Professor Redley's presentation and our young colleagues' presentation from Japan and Korea, it's very interesting, and we think there is a good future for the management of head injuries.
No more questions? So be there on stage. Now I would request Dr. Peter Relly to present the mementos to our eminent chairpersons. Professor Dr. A.C. Mohanty. Let's have some applause, please. Thank you, sir. Professor Dr. Sanjeev Mishra. Thank you, sir. Professor Dr. D.K. Satpathy. Thank you so much, sir. Now we'll be having a small tea break. So we'll be resuming by 3:40 p.m.